Hi everyone, and welcome to Digitodontics Webinar Series. This is Mohamed with you today from Digitodontics International Academy. It's our pleasure to welcome our guest speaker, Dr. Mohamed Said from the Faculty of Dentistry, Mansoura University, Egypt. Dr. Said will share with us his experience in the digital workflow in implant prosthodontics as an overview. Dr. Mohamed Said is an assistant professor at the Department of Prosthodontics, Faculty of Dentistry, Mansoura University, Egypt. In 2006, he earned his bachelor's degree in dentistry from Mansoura University. As he has always been passionate about prosthodontics, he joined the prosthodontic department at Mansoura University in 2009. As a teaching assistant, where he had many tasks to perform, such as research, teaching, and clinical work. During that time, he decided to go overseas to seek more advanced dental education. In 2010, he received an offer from the University of Hong Kong to study for a master's degree in oral rehabilitation. After gaining his master's degree from Hong Kong University, he moved to Tokyo to study for a doctorate degree in maxillofacial prosthetics, where he obtained his PhD from Tokyo Medical and Dental University. In 2021, he moved to the United States at the Department for Prosthodontics of the Faculty of Dentistry, the University of Iowa, for postdoctoral training. And in the beginning of 2022, he returned to the Mansoura University as an assistant professor of prosthodontics. So just before Dr. Said starts, I would like to mention that attendee can write their questions in the chat side or Q&A side, and then in the end, Dr. Said will answer those questions. So once again, it's our pleasure to welcome Dr. Mohamed Said to share with us his experience in the digital workflow for the implant prosthodontics. So Dr. Mohamed, I think the stage is yours now. You can share your screen.
Thanks a lot for your nice presentation about myself, and I'm really happy to be here with you today. And I would like to thank you for inviting me to participate in this nice webinars that you are doing right now. I think it's a huge work, and it should be appreciated. So thanks a lot, and I think this kind of sharing knowledge is very important nowadays, especially when we have this kind of facilities using the internet to invite many people from all over the world to share their knowledge and experience with all of us. Thank you. And today I'm here to share with you my presentation about digital workflow in implant prosthodontics. As Dr. Mahmoud mentioned, my name is Dr. Mohamed Said. I am an assistant. My presentation. Okay. I am an assistant professor in prosthodontics, Faculty of Dentistry, Mansoura University, and this is our faculty department member. And this image was taken while we are doing a joint seminar between prosthodontic department, Mansoura University, and maxillofacial prosthetics department in Japan. And all the staff, most of the staff members in maxillofacial prosthetic department in Japan came to Cairo, and we have a nice time there, and we shared a huge knowledge and experience in the seminar. On the right hand, you can see how Faculty of Dentistry building in Mansoura University looks like, and this is the main building, and there is another building where we have all the clinics and clinical training for the students. My important milestones, as Dr. Mahmoud shared with you, I already graduated in 2006 from Mansoura University. After that, I seek further education abroad. I got an offer from Hong Kong to study an MPhil, a Master of Philosophy in Oral Rehabilitation. I graduated in 2012. It was a very nice experience in Hong Kong. And nowadays I miss Hong Kong a lot, but I hope, because Hong Kong is a very lively city, and I think it's one of the most fabulous cities I have ever visited. And I hope to visit soon when everything getting back to normal after the COVID time, because they have a lot of restrictions nowadays. Another important milestone in my career, when I got my PhD from maxillofacial prosthetics in TMDU, I graduated in 2018. I spent a lot of time with Dr. Mahmoud there. We almost spent like 4 years together. It was a very nice company, and we spent like very nice time together in maxillofacial prosthetic department. I still miss Tokyo a lot. I miss the food. I miss the people. I miss the trains, everything in Tokyo. I'm still missing it right now. And I hope I can visit Tokyo again in the near future. In 2021, I decided to go further abroad for further education and training. I went to University of Iowa Prosthodontic department to do like a postdoctoral training. It was a clinical training supposed to be for 3 years, but I decided to spend just only 6 months, and I decided to go back and start over again in my home university as an assistant professor. And I'm working now as an assistant professor teaching pros, and we have many students here. We have like an undergraduate student and a postgraduate student, and I'm going to share with you some of the work of my student, my master degree student, in this presentation. So my presentation today is about digital workflow in implant prosthodontics. As we all know that we have like different workflow in our implant treatment. And the most common and conventional one is the analog workflow, which is the conventional workflow. And nowadays we have a huge advances in digital technology that allow most of the clinicians to start using the digital technology to do a digital workflow for their cases and patients. And most of us nowadays are trying to like start using digital technology, and that's why we are having like this kind of combination of both analog and digital workflow. So we don't have like most of us don't have like a pure digital workflow, but at least we have a combination between both. So we do some stuff in analog or conventional way, and in the middle or during other steps, we can use the digital workflow. For years, analog technique was the predominant method used in implant prosthodontics. And as we know, we used to have like a diagnostic impressions using alginate to get diagnostic stone cast. And using the diagnostic stone casts, we can do like diagnostic wax-ups. And diagnostic wax-ups, like we spend hours in the lab doing this kind of wax-up in order to get like a smile design or restoration design or whatever work you are doing. And also, we sometimes when we are doing like an implant case in a conventional way, we ask for a radiographic stent that we use for the patient to get like a CBCT in order to start doing a surgical stent in the lab that will assist us doing the implant surgery. And after placing the implant, we wait for time for healing. And after healing, we will start doing the final prosthesis using the regular casting techniques. And this is what we used to do before, like in the past. But nowadays, we have the evolving digital technology and it went into the modern oral implantology and gave us like new clinical workflows. We can do digital impressions using intraoral scanners or extraoral scanners. When we have the data on the software, we can start doing like digital wax-ups that doesn't take long time as the regular wax-ups that we spend hours in the lab doing that kind of wax-ups. We also have the option of doing CBCT in order to get DICOM data for the patient jaws. And also, when we have the CBCT and the STL file from the digital impression, we can start designing our surgical guides that will assist us placing the implant in the desired positions that we want. And this surgical guide, we can just use the 3D printing techniques in order to print it. And after placing the implant and having the implant healed and anchored in the bone, we can start doing our final restoration using the CAD/CAM technique that we have right now in our hands. So to summarize the digital workflow, and this image from the digital workflow in implant dentistry book, the ITI treatment guide, and it summarizes the digital workflow. And as you know, a fully digital workflow consists of diagnostic steps, planning steps, surgical steps, and prosthodontic steps. These are the 4 main steps that we do while we are doing a digital workflow. It begins with the data files obtained with an intraoral scanners to get an STL file, and a CBCT to get the DICOM file, and we merge both files on a planning software. After merging as we can see here, includes the STL file and the DICOM file in Crown, and then we merge both together to start planning for the implant position virtually before placing or before going into the surgery. And after planning for the implant position guided by the desired prosthetic design, a surgical guide can now digitally design and 3D printed to assist the implant placement, as we can see here in this image. After osseointegration period, the digital impression is taken again, and STL file is moved to a CAD software to fabricate the final procedures. And this is like a simple summary of our digital or a whole or a full digital workflow. So as I mentioned, there are 4 important steps while we're doing the digital workflows: diagnostic steps, planning steps, surgical steps, and prosthodontic steps. And we are going to talk about each step in a brief way. Diagnostic digital models obtained with intraoral scanner or extraoral scanner from a physical diagnostic model. So we can go directly to the patient and scan the patient to get a diagnostic digital models, or we can get a regular impression and use an extraoral scanner for scanning the physical cast to get a digital model. And these impressions are normally present in STL file format. STL files are relatively easy to handle and should be kept as a part of the patient electronic health record. Digital diagnostic models can be imported into a CAD software to plan your design. Another method is 3D imaging, which is CBCT, to obtain a DICOM file. So DICOM files render a 3D volumetric representation of the scanned object with a relatively poor surface definition. Various software packages exist for viewing or manipulating DICOM files. And this software interface showing one of the softwares for the DICOM file of one of the patients that we are treating. And as we can see here, it shows the axial section, the cross section on the right, and the panoramic view and the 3D view. And from this step, you can start diagnosis, whatever you want to do regarding the treatment that you are offering for the patient. The DICOM files can be merged with the STL file in a virtual implant planning software. As you can see here from the image of the digital workflow in implant dentistry, the ITI treatment guide. In yellow, you can see the STL file. And in green, you can see how the DICOM file has been segmented and separated and merged into the STL file. Then from this step, we can start planning for our restoration. And after we plan for our restoration, we can virtually plan the appropriate restoration-driven implant position. So we plan for the restoration first, and depending on our restoration, we can do our restoration-driven implant position. We plan for the implant position depending on our restoration position. In edentulous patient, we usually implement the dual scanning technique. So what is the dual scanning technique? We first start with doing a regular denture for the patient, and we always have many edentulous patients in our department here in Mansoura University. And what we usually do is doing like regular denture first. And if the patient accepts to go for 2 implant over denture, we start duplicating our denture with acrylic resin. After that, we are going to use this duplicate denture. After doing some radio-opaque markers in the denture using Persia in order to show, allow the patient to scan, to getting scanned using a CBCT. So the patient is going to be scanned with the duplicate denture in place. And after getting the scan, we will get this kind of like image, which showing the bone with this radio-opaque markers. So we can plan for the appropriate position of the implant depending on the markers that we have on the radio-opaque markers. But how can we place the exact like relative position of the teeth and radio-opaque markers regarding the bone and anatomical tissue? So what we usually do after scanning the first scan, it's called dual scan technique. So the first scan is scanning the patient with the denture, and the second scan is scanning the denture, the denture itself alone. And then after having the 2 scans, like the patient scan with the denture and the denture scan by itself, and then we will use these 2 scans to be merged together in the planning software. Following this step, the appropriate implant can be selected from the digital library and appropriately positioned relative to the adjacent anatomic structures, and the prosthodontic planning starts from there. So we do dual scans, one scan with the patient, one patient is scanned with the denture, and then the denture is scanned by itself, and the denture has a radiographic markers. After having the 2 scans, we are going to submerge both in a planning software, and after having the 2 merged scanned in the planning software, we will start planning for the implant position relative to the restorations that we have, the dentures that we have, and the radio-opaque markers that we have in order to place the implant in an appropriate position in relation to the anatomical structure and in relation to the restorations that we already have. Now we go for the surgical steps. So once the implant position has been defined, virtual implant planning software can be used for digital designing of a surgical guide. So at this step, we are planning for the surgical guide. This design is then exported and as a STL file for a 3D printer or milling unit for manufacturing of the design guide. The surgical guide will assist us for accurate implant placement by transferring the planned implant position to the surgical field. And it is important to verify the clinical fit and the stability of the guide. Because if the guide is not very stable enough, or it's not like accurately fit in place, probably you will place the implant in a different position, not the position that you have planned for. If we have like a remaining teeth, we can have the option of verifying the accurate of the fit of the guide by having some windows, as we can see here from this image. We can have some windows here in order to allow for us to visualize how the guide is fitting over the teeth. So by having these windows, we can see if the guide is fully seated and stable or not. And for edentulous patient, we usually have a mucosal supported surgical guide. And these cases are very challenging because the mucosa is moving. It's moving in the mouth. It's not stable like the teeth. So we always, as we mentioned, go for the dual scan technique, plan for the implant, and then after planning for the implant position, we will start designing our surgical guide. And we always fabricate like or do the bite. So we will have the upper denture in place, and then we will use the surgical stent with a guide in order to allow the patient to bite over the surgical guide using the upper denture with the bite in place, like silicone bite. And while the patient is biting, I will start fixing the surgical guide, the mucosal surgical guide with the anchor pins. And then I will remove the upper denture and start making my drilling into the bone. So this is one of the cases that we have done here in our dental school by our master student, Dr. Ala, and Dr. Nadia, under my supervision, and Dr. Salah Higazi, the head of department supervision. And they are doing a great work, and they already graduated, and they have like very nice cases during their study. And this is one of the cases that I'm going to show to you. So we have printed the surgical guide, and now we will start use the surgical guide for implant placement. As I mentioned, we place the surgical guide in place, and we always have a silicone bite, not like that. We always have like a silicone bite with the upper denture to make sure that we are having this surgical guide exactly in the desired positions that we want. And we have like 3 holes, as we can see here. 1, 2, 3. Then we will start drilling through these holes using a drill. And we are going to drill like 2 to 3 millimeters transmucosal, and then we will use the anchor pins to fix the guide in place using hand pressure. So we use drills through these 3 holes, and then there is like a very long pin that goes into the bone, 2 to 3 millimeter transmucosal, to stabilize the stent in place. After that, we will start doing our tissue punch, and then we will go through the sleeves of the stent here to locate the exact position for the drilling. After doing the tissue punch, we will remove the stent to allow for easy removal of the punched tissue and see exactly where the implant is going to be placed. Then we will reposition the surgical guide again and start the drilling of the implant position. We always have like this kind of keys, and for each key there is a corresponding drill. So depending on the diameter of the drills that you are using, you are going to use the specific key for this specific drill. So as we can see here, for diameter key over the sleeve, as you can see here, this is how the key is going to be placed. And then from the key, you are going to drill through the bone and the tissue until you reach the exact length that you aiming for. And this is how the 2 implants look like after placing the healing abutment. So in this case, we are planning for 2 implant overdenture. And this is after healing the implant, and this is a post-operative CBCT showing the implant inside the bone with the desired implant position and location. Okay, so why we are using digital implant surgery? It's relatively easy. It doesn't need any skills. You just place the surgical guide and then drilling through the sleeves, screwing the implant. You don't need to make like a huge surgical field. You don't have to open big flaps. It will allow to reduce their surgery time. And as I mentioned, it is a flapless approach. It reduces the post-operative discomfort for the patient. It reduces the time, but it has, on the other hand, some complications, such as fracture of the guide. So we have to make sure that the guide has enough thickness to be able to manipulate without getting it fractured. So this is one of the complications that we can encounter while we are using the surgical guide. So after placing the implant and the implant has been osseointegrated, we will move to the prosthodontic step of the digital workflow. So after successful osseointegration, we will start doing like intraoral scanning for the implant to move the implant position from the oral cavity to the digital lab. So why we do digital impression? We do digital impression to reduce the risk of distortion during the laboratory phase and improve the patient comfort and acceptance and improve the efficiency. As we know, half of the misfit is introduced during the impression procedures and production of the stone cast, while the other half of the misfit occurs while manufacturing the prosthesis itself. So, in 2004, the first digitally scannable implant component were introduced by using an innovative coded healing abutment. This was the first introduced scannable. It hasn't been called scan bodies yet, but they used to call it like a digitally scannable implant component. Contain 3D information about the implant position coded on its surface. So you are going to see some codes here that will be recognized by the scanner in order to give some information about the implant relocation in relation to the adjacent teeth, opposing dentition, and surrounding tissue. After that, many scan bodies has been introduced to the market, and scan bodies are a complex implant positioning transfer device that play an essential role in the digital workflow and fabrication of accurately fitting implant-supported restoration. And this image shows how the scan bodies looks like. It consists of 3 regions, which is the first region, which is the scan region. This is the region where the scanner gets the information from the scan body, and then the body itself, and then the base. And some of the bases are made from metal and other made from like PEEK or whatever materials that they are using. And this image shows how the differently intraoral scan bodies looks like. There are many commercially available scan bodies in the market. Some of them can be used like unlimited, and most of the unlimited scan bodies, you will find that it has like a metal base, like this one. So it doesn't getting like distorted while you are tightening it or unscrewing it. And some of them, which is made of PEEK, should be used like a single use and should be discarded. And some of them you can use like 10 times, depending on the type of scan body and the base of the scan body itself. Some of them are made of PEEK, the body material, and some of them are made of titanium. The usage of different scan bodies depending on the type of implant that you are using and which scan body is compatible with the implant that you are using. So it depends on the type of the implant itself. And most of them can be scanned with any scanner, but some of them should be like this one with trace scanner. So you have to know which one is compatible with your scanner and which one is not compatible with your scanner. So after scanning and scanning the scan body in place and moving this data into the a CAD station for designing, we will move the ST file into a CAD station to begin the prosthetic fabrication by using the CAD software. The digital implant analog can be placed, as we can see here in this image. So after scanning and moving the data into a planning software, the software has some like library depending on the implant type and the intraoral scan body. So it will figure out which type of scan body that you have been scanning And then from the library, you can select the type of the implant, and it's going to locate or position the virtual implant in place. And dentistry specific CAD software is used in fabrication of the restoration after positioning the implant to fabricate the final restoration at the end. So the image on the right, you will see that we have only the implant and the restoration design over the implant. And we have the image showed that model has been made transparent in order to allow how the restoration or the final restoration looks like. So we can manipulate the software in different ways in order getting the final restoration in the best fit, in the best shape and best look. So we have more than one option in order to fabricate a single unit crown. The first option, after scanning, after scanning the place that we are going to restore, is to, after scanning, we can just fabricate a monolithic crown and cement this monolithic crown over a value-based, ready-made, prefabricated titanium abutment. So this is one of the options. So we can scan, getting the data in the software, and then we can design a monolithic crown that will be bonded over a ready-made titanium abutment. And then after cementation of the abutment, after cementation of the crown over the titanium abutment, then we can screw the whole retained full contour restoration into the implant. The other option is designing a custom-made titanium abutment. So we are going to scan, and then we have the implant after scanning virtually positioned in its place, and then we will design for a titanium abutment, custom titanium abutment. Then we will fabricate a monolithic crown that will be cemented over the titanium abutment, the custom titanium abutment, and then we will screw a one-piece screw retained full contoured restoration over the implant. I hope you can get the difference between both, but both of them are the same idea, except that we are having a ready-made titanium abutment in the first option. It's called a tie-based or value-based abutment. So this is coming from the manufacturer itself. We screwed it over the implant, and we cement before screwing the tie-based abutment, as we can see here in figure B, we cement the monolithic crown over the tie-based abutment, and then we screw the whole assembly into the implant. On the other option, on the other hand, we can fabricate a custom abutment, a custom titanium abutment using the software. And then after fabricating the custom abutment, we can design for a monolithic crown that is going to be cemented or bonded over the custom abutment. And then we screw both assembly or the whole assembly over the implant. So what about the cases that we are doing in our department? In some cases like this patient wants to have a fixed restoration and doesn't want to have any removable. So we plan for an implant, 6 implant positions. And after placing the implant and having all implant osseointegrated in place, we plan for a metal framework that will be screwed directly into the implant, as it showed here in this image. So we took a regular impression. So this is what I'm talking about at the beginning. We have a combination of both analog and digital workflow. It's not a whole digital workflow in this case. So we have a implant placed, but in this case, we needed to do some grafting. So we needed to have doing a flap approach, extraction of the teeth. There are some preapical lesions that need to be cleaned, doing drilling, some bone augmentation, and guided bone regeneration and suturing. And this is how the implant looked like after healing. After that, we start doing the prosthetic treatment. We took a regular impression using open tray impression technique, and then scanning the impression using an extraoral scanner. And then after that, we planned for a metal framework that is going to be screwed directly onto the implant. And after we checked for the fit and accuracy of fitting and passivity of the framework, we cemented the zirconia crowns over the metal framework that we have fabricated and doing some composite pink composites over the crowns in order to give the pink color of the gingiva and don't have very long teeth. That's not going to be very aesthetic. So in this case, we had both combination of analog and digital workflow. Another case that we are doing in our department by our master students. So as I mentioned, we sometimes do implant over dentures using locators, or sometimes we do implant over denture using bars. And one of the research projects that we are working on right now is doing implant over denture using zirconia bars. So instead of using regular metal bar, we are trying to use zirconia bar instead of the metal bar and seeing how this is going to function in the patient mouth. So in this case, the patient is coming for implant over denture. We offered the treatment for the patient of getting 2 implants with bar connecting the 2 implants together and then placing an implant over denture over the bar, and the patient accepted to proceed. And this is how the patient looked like with his denture. And this ExoCAD interface showing the STL file of a scanned model, including 2 implants and 2 tie-based abutments. Here, this is the 2 implant with 2 tie-based abutments. So after moving the data into the software, we started designing for the bar assembly. So it's going to be a tie-based abutment and planning a zirconia abutment that's going to be cemented over the tie-based abutment to be placed in over the implant. And this is how the bar looks like after designing. And this is how the finished zirconia bar assembly looks inside the patient mouth. And now we can see how the zirconia bar can having better aesthetics compared to the metal bars that most of the patient doesn't like, even when they cover it with the denture. I know that during function, it's not going to be huge difference, but something psychologically inside the patient that they having something like white, it's not like black. So after fabricating the zirconia bar and cemented over the tie-based abutment and screwing the assembly over the implant, we planned for a beak framework. This is going to be incorporated inside the denture in order to retain the denture in place. And this is how the beak framework looks like intraoral. This is try-in step. And then this is the over-denture fitting surface showing the beak framework being incorporated inside the denture itself. The good thing here is that the patient having a very good stability of their lower denture, and they feel that it's fitting really nice and it's not moving inside their mouth. And to summarize my presentation today, I'm going to using this graph from a very nice systematic review that was done in Ohio University State, in Ohio State University by Dr. Mizumoto, and it shows how the digital workflow could be done. And as I mentioned, the first step should be just scanning the scan body and digital scan using intraoral scanner. The scan body surface matching in the CAD software. We start matching the scan body in the CAD software with the implant library in order to select the virtual implant that's going to be placed over the scan body. Implant. Now we start implant reposition in the digital model. And at this step, we can just go whether analog or digital. If we are going analog, we have to print the model in order to going for a conventional processes, conventional processing and fabrication. And if we are going digital and we would like to continue in a digital way, we will start planning for the abutment, whether it is custom abutment, custom titanium abutment, or a custom framework like the case that I have showed to you, or a restoration designed and processed in a CAD software using the digital model. So it's going to be all digital. It's going to be an abutment or framework or restoration designed and processed in the CAD software using digital model. And after that, we are going to use the CAM, which is computer-aided manufacturing fabrication. And we can go back and forth between analog and conventional, analog and digital, depending on the facilities and the techniques that we prefer. But at the end, it's kind of preference right now, but I think in the near future, we can go, and as Dr. Mahmoud always prefer, we can go whole digital. And I think by having like this Digitodontics platform will give us the courage to go forward and start implementing our digital techniques in our treatment every time. Thanks a lot for your time, and I enjoyed sharing my cases and my experience in implant prosthodontic with you, and I'm open to receive any questions that you want to ask.
Thank you so much for really nice presentation. You dived us to the conventional way. You started your presentation to show us the conventional and the analog way for the implant prosthodontics, which is still used in many places worldwide. And then you start to combine the digital workflow to the conventional one, which is most of the nowadays they are using this kind of hybrid technique where they use conventional and digital workflow. And also you mentioned this structure for the fully digital workflow for implant prosthodontics, and sooner or later we are heading to the totally digital workflow for implant prosthodontics. And many advanced institutions actually now they doing every single step by digital workflow. Just to check if we have any questions from the we don't have any question yet, but again, if anyone would like to write the question, so Dr. Mohamed will be happy to answer those questions. So Dr. Mohamed, I would like to ask you, you are in an environment that teaching undergraduate and postgraduate students.
Yeah.
And I guess most of students are interested to have the experience and take the challenge of the digital workflow. Could you touch on the student experience on the using some kind of digital techniques to provide the implant treatment for the patients, please?
For undergraduate students or postgraduate students?
Actually, you can mention about both, because you're also providing the teaching for the undergraduate and postgraduate. So that's my second question. How do you integrate the digital workflow in the lectures and the teaching for the undergraduate and postgraduate students as well?
So for the undergraduate students now, we are still doing like theoretical only. So we started giving some lectures about the digital work in every aspect of dentistry. Like in pros, we started showing them how the scanners looks like. So we have some lectures about digital dentistry. and we are showing them some videos about scanning, designing, planning, whatever kind of digital work that we are doing, and we are trying to getting them familiar to the digital world. But as you know, when we go to the clinic, they still getting the training of the basics, so they don't have the facility to, and we don't have the facility to train every single student about digital dentistry. But when we go for the postgraduate student, we having the feasibility of allowing them to get trained on some scanning techniques, and we have some companies that offer some workshops that come to our dental school and showing the scanners and milling machines and stuff like that, and by this way we have some exposure for our postgraduate student with digital dentistry.
So from your experience, what the most challenging that facing you and your team to provide more digital workflow in your institution?
It's a financial issue, because as you know, getting like a whole set of digital setup, it's really expensive, and the maintenance and the usage of this kind of setup needs like a maintenance fee and software that need to be like renewed every year with additional cost. So financially is like the most challenging part, but on the other hand, we have private labs here that having all the facilities that we need, and sometimes we get in cooperation with them. They even have some of them having like the intraoral scanners, and they offer it for like, some of them offer it for free, and some of them offer it for like a small amount of money, so we can get it into our department and start using the scanners and software that they have, and the students who are willing to learn more, they can go ahead further with the digital technician, and start the designing and planning and stuff like that. And most of them having all the CAD/CAM machines, and we have like some other radiographic centers that have the CBCT and printing printers that we could use for printing the surgical guides. So it's a little bit challenging, but still, if you want to learn, you will find the ways to do that.
I totally agree. Yeah. So one more question. In regard for research in your institution, and that's mainly for the implant prosthodontics, nowadays some kind of open access softwares are available. And have you tried to test those kind of software in terms of accuracy and the usability of the software, especially that you still have master students, so that they can test those kind of machines in terms of getting visibility to them, to have some kind of exercise with those kind of software?
Yeah. While I was in United States doing my clinical training there, I've been there like 6 months, and I had a chance to work on some of the free softwares. It wasn't like a huge exposure, but I had a chance to try. So one of the free softwares that we used to use there is the Blue Sky Bio. And Blue Sky Bio is giving like a huge advantage for anybody who would like to try a software for free. And we used to use this software for designing the surgical guides. And I can tell you that they provide us with a software that we could use to plan and design a surgical guide with a very huge accuracy. So after planning the surgical guide, and merging the CAD, the DICOM file with the STE file, and plan the surgical guide depending on the restoration driven, prosthetic driven restoration. We print, we move the STE file of this of the surgical guide to a printer, and we print the surgical guide with a very huge accuracy, and then we could use it in the surgery for implant placement. So some of these softwares are really a huge advantage, and I advise everyone to try. And there are many tutorials on YouTube that will teach you how to use it and make your design.
Thank you. Actually, we don't have questions, but we do have 2 comments. So, Dr. Zhao, thank you for the presentation. And Dr. Ramesh, he asked, please kindly provide us the presentation. So, in a few days, the recording of the presentation will be available on the Digitodontics platform. So stay connected and you will see the presentation.
Thank you very much for your comments.
Yeah, so Dr. Mohamed Said, I'm so glad to having you with us today. You inspired us by your presentation, presented us through different implant prosthodontic digital workflow, and you give us your own experience in your institution. And we highly appreciate what you have doing, although there is no that much of the financial support to be working fully in digital workflow, but you have done a great job through the cases that you presented to us. So thank you so much for your time. So as a tradition for us, it's our pleasure to present Dr. Mohamed Said a certificate of appreciation. So we hereby express our sincere appreciation to Dr. Mohamed Mustafa Said in recognition of his contribution as a live webinar speaker for the Digitodontics Webinar Series on the topic of digital workflow in implant prosthodontics, an overview that was presented on Tuesday, July 26, 2022. So, Dr. Mohamed, thank you so much for your time and engagement with us. And I wish you have a nice day. Thank you.
Mahmoud, for inviting me being with you today, and thank you for everything. Thank you.
Thank you. Bye-bye.
Bye.